Hello, this is Robert Lee, and this is a brief video summarizing hypofractionation in the treatment of prostate cancer. Before we get to the data, let's summarize some of the advantages. Clearly, completing treatment in 4 to 5 weeks or 4 to 5 days is a lot more convenient for patients than 8 or 9 weeks. In environments where linear accelerators are scarce, then using less of those resources is a good thing. In the United States, at least, it's clear that lower number of fractions is less expensive, leads to lower costs. Finally, the real question is whether hypofractionation is in fact better, increasing efficacy. So this summary slide is 4 small trials, relatively speaking, that looked at moderate hypofractionation, typical 4 or 5 week regimen compared to a 8 or 9 week regimen. All of them have a superiority design. They differ in that their eligibility criteria are different. Sometimes hormonal therapy is used, sometimes it isn't. There's really no consistent finding, other than most of the comparisons didn't really reveal any difference. In one study, the moderate hypofractionation was worse, and in one study, there was actually some evidence that moderate hypofractionation was better with regard to efficacy. All of these studies are relatively small and limited in the ability to generalize how does moderate hypofractionation work. We do have the benefit of 3 large studies, all of them with non-inferiority hypotheses, more than 5,000 patients included throughout North America, Europe, and Australia. The first study to be published is RTOG 0415. It included low-risk men and compared 73.8 and 1.8 gray fractions to a moderately hypofractionated regimen piloted by Pat Capellian during his time at the Cleveland Clinic. In a third planned analysis, the Data Monitoring Committee dropped the F-bomb, meaning that they declared futility. There was, in their minds, no way that the would be ever any difference between the 2 arms, and they recommended that the results be made public. This is the primary endpoint for the study, which was disease-free survival. You can see the control arm and the experimental arm, no difference in disease-free survival. The hazard ratio comparing the 2 curves is 0.85, favoring the hypofractionated arm, and this meets the predefined non-inferiority criteria. There was some difference in late effects, a slight increase in grade 2 GI late events with the hypofractionated arm. The same effect was seen in GU toxicity, a slight increase in grade 2 events in the moderately hypofractionated arm. The next study is the CHIP study, which is a large study of 3,000 men. It's a 3-arm study comparing 2 different moderate hypofractionated regimens. 74 gray at 2 gray per fraction, 60 gray at 3 gray per fractions, and 57 at 3 gray per fraction. Most of the men had intermediate risk disease, although some had low and some had high. Nearly all the patients received a short course of ADT, which was the standard of care in the UK at the time. Looking at the primary endpoint, basically the authors concluded that 60 gray is non-inferior to 74 gray, but 57 gray, in fact, is not non-inferior. Toxicity, GI, did not differ according to treatment arm. GU toxicity, again, did not differ according to treatment arm. The third study in this trifecta is the PROPHET study from largely Canadian centers, intermediate risk disease, no hormonal therapy allowed, 1,200 patients, comparing a high standard 78 gray at 2 gray per fraction to 60 gray at 3 gray per fraction. Primary endpoint was a biochemical endpoint. No difference in biochemical recurrence according to treatment arm. Hazard ratio as you see there, and this met the predefined non-inferiority criterion. No difference in late GU toxicity on the PROPHET study. No difference in late GI toxicity. This is a summary slide of the 3 non-inferiority studies. The findings are relatively consistent in that all of them met the non-inferiority criterion. There was one outlier. The RTOG study did find more grade 2 toxicity, GI and GU, for the hypofractionated arms, but the larger studies found no difference. And most importantly, the patient-reported outcomes from all of the studies showed no significant difference between the standard arm and the hypofractionated arm. This is speculation, but I believe that the excess toxicity observed in the RTOG studies are related to 2 things. Number 1, the control arm is relatively low at 73.8, and probably more importantly, the rectal constraints for this study were much more liberal than the CHIP study or the PROPHET study. So summarizing moderate hypofractionation, more than 5,000 patients treated on 3 different non-inferiority studies all support non-inferiority. There's no increase in severe toxicity. And importantly, there's no evidence of improved efficacy either. This is a segue slide to move into more extreme fractionation schedules using 5 fractions. We do have 2 randomized trials that have been reported. Only one has reported efficacy. This is the first one. This is a study from Sweden in Scandinavia. Anders Widmark is the PI. Published last year in Lancet. This is the primary endpoint, which is failure-free survival. Hazard ratio right at 1. This is a non-inferiority design. No evidence that an ultra-hypofractionated or an extreme hypofractionated regimen is inferior. This is the other study that has been reported on, PACE-B study, 78 gray at 2 gray versus 36.25 at 7.25. Toxicity is the only thing that's been reported last year in Lancet Oncology. What you see is a little bit more GI toxicity that is seen sooner with the hypofractionated arm, and similarly GU toxicity is seen sooner, and it does tend to peak out a little bit more, but within a few weeks to months the results are pretty similar. So summarizing the extreme regimens, or SBRT, we have lots of phase 1 and 2 trials. I have not presented them. We have 2 randomized trials that have reported early toxicity and suggested it's similar. Only 1 randomized trial to date that has evidence about efficacy but suggests that the extreme courses seem to work as well as more prolonged conventionally fractionated courses. Here are the resources. Thank you.